Welcome to our next lesson, reversing insulin resistance. So I would hope that at this point you have seen the impact of insulin resistance on cardiovascular risk and why it is such an opportunity to reverse it. And this is something that I really want to get across, that reversing these phases of insulin resistance across even the extreme ends of the phenotype is possible. So what we're going to cover here is why reversing insulin resistance is a crucial strategy to take. We're going to look at exercise and how it impacts on insulin resistance phenotypes. We're going to go into exercise physiology a lot more in depth in later lessons, but this is just going to be a high-level summary of how it impacts insulin resistance. And also nutrition, again, will be dealt with in much more detail, but really a high-level summary of how nutrition impacts on reversing insulin resistance. So as we spoke about before, insulin resistance really is that fuel on the fire of other cardiovascular risks. It often acts as a major accelerant of risk factors, and particularly cardiovascular disease. Not exactly a true isolated causal factor, but a big amplifier of risk. Again, just as a reminder, if we look at insulin resistance as a predictor of age-related diseases, those in the higher insulin resistance categories are at much higher risk of developing most of these diseases specifically mentioned here: cardiovascular disease, cancers, hypertension, strokes, and diabetes. We've spoken about multiple times the amplifier effect of insulin resistance on having high ApoB or high LDL-C concentration, whereas having both of these in the higher ranges significantly increases cardiovascular risk over time. So the goal here is to optimize both of these over time. So again, the thing to really emphasize here is that insulin resistance is reversible and exists along this continuum that we have talked about multiple times. The idea that someone is either insulin sensitive, but as someone gains additional visceral fat generally and exceeds their personal fat threshold, they move into this range of insulin resistance, non-alcoholic fatty liver disease or metabolic fatty liver disease, then metabolic syndrome, prediabetes, diabetes, etc. as we move up and down the scale. And we can move right back down again. Ideally, earlier is better in that journey. As we spoke about, the biomarker that actually identifies your risk here is high levels of fasting insulin generally. So back to our model here in terms of how we can conceptually reduce risk. We can go about this in terms of reducing carbohydrates, but reducing carbohydrates is in service of reducing calories. So again, I just want to really double click on this. Reduction of carbohydrates as in a low carbohydrate diet can often be for many people a really, really great tool, but it is not the only tool. It is in service of reducing caloric intake to reduce visceral fat. So but it's just important to highlight that. Secondly, it's about increasing exercise to increase muscle sensitivity so that you can dispose of glucose in a much more efficient manner and store it safely as glycogen. And thirdly, reducing visceral fat, which primarily comes from reducing calories, which is again in service of reducing carbohydrates, which is decreasing the substrate in terms of an input. Now, we know that even a single bout of exercise can improve muscle insulin sensitivity by about 40%. So it is really important. Every single piece of activity that you do during the day really matters. If you look at regular exercise, it really improves the health of your mitochondria, and improving mitochondrial function is really a component of metabolic health and increasing insulin sensitivity. We know from studies of 4 to 6 sessions of exercise per week over about a 12-week period significantly increase the number of mitochondria in the muscle and also their function and improving insulin sensitivity and resistance parameters. Now, often it is when someone gets into this latter stage of metabolic syndrome, prediabetes, and diabetes that this is the primary goal here. But I would argue that even in that insulin resistance phase is when it's easiest to manage it and actually reverse it. So the question becomes diet or exercise. People fall into very, very dogmatic camps here, and the reality is that you have to do both. Because if you look at studies here in terms of insulin sensitivity, so higher is better on this graph, and you look at pre and post, so pre is in gold, post is in white, and you look at people who use a nutritional strategy alone. Insulin sensitivity, yes, improves. So that's good. Fantastic. Use a nutritional dietary strategy. But if you use diet and exercise, it improves even more. So the answer is always both. And the line here is you can't outrun a bad diet and you can't outdiet not exercising. So never just focus on one. This idea that you can choose one particular dietary strategy and not focus on exercise is really a fool's errand, and you should use both strategies that are available to you. If you look at studies on reversing pre-diabetes down into the diabetes state and outcomes on those who don't, if you look at the group who go from pre-diabetes and progress on to diabetes, and you look at the risk of death from all-cause mortality, there's about a 50% increase, and that is obviously concerning. If you look at the group who go from pre-diabetes to no diabetes, so go into remission, you see that there's no change in terms of increase or decreased risk, and that is surprising. So why is that? But if you actually look at these groups and separate them out by the people who did exercise or did not exercise, i.e. used nutrition alone versus nutrition and exercise, you can see a significant difference. So the people who were physically active, who reverted their pre-diabetes to no diabetes using nutrition and exercise, had a 28% reduction in all-cause mortality. So again, nutrition and exercise is key. When we look at reversing diabetes, you can actually look at some really interesting studies for this. If you take people who have diabetes with an elevated BMI greater than 27, and importantly, they've had diabetes for less than 6 years and are not on insulin. So this is people who are in the early phases of diabetes rather than late onset, not late onset, my apologies, but long-term diabetes, where often their beta cell function of the pancreas has been very much burned out. So you have the opportunity to restore function here. And you randomize these groups into either calorie-restricted diet and withdrawal of the diabetic medications, or just standard advice that actually people get. So if you look at the control group in terms of people who have basically reverted or gone into a remission of the diabetes at 1 year, about 4% of that population. So a small percentage of them did go into remission. But if you look at the intervention group, about 46% actually went into remission from their diabetes. So this is a huge change in terms of this is not going from insulin resistance to insulin sensitivity. This is going from diabetes all the way down the chain here in terms of getting back into the normal range. Certainly from a glycemic point of view, you may still have a degree of insulin resistance. But then the question is well, how much weight do I need to lose in terms of actually doing this? And if you stratify out this 46% of people, and you look at the amount of weight loss that people have at 1 year and the probability of them actually reverting their diabetes, you can see that no weight loss means no chance of actually remission at 1 year. If you're losing less than 5 kilograms, sorry, you're kind of at about 7% chance of remission. But as you go above 5 kilograms, in terms of 5 to 10, 10 to 15 kilograms, and above 15 kilograms, the probability of going into remission, of reverting your diabetes back into the normal state, increases dramatically. Now, this is in individuals who have diabetes early onset and have a BMI greater than 27. But what about people who have a BMI of less than 27, which is kind of getting closer to the normal range, and even including people in the normal range weight category? So diabetes and BMI less than 27, and you incur a 10% weight loss. So not a very extreme weight loss, but a moderate weight loss nonetheless. And you can see here diabetes reversed in approximately 66% of patients. And this is now in patients who have a ostensibly normal weight. So the BMI is really only up as high as 26. So you can see here, this really brings credence to this idea of the personal fat threshold, where even some individuals who gain a small amount of weight disproportionately is impacting their visceral fat and is driving their insulin resistance. So insulin resistance, reversing it, even along the whole continuum, is entirely possible, but it's much, much better if you go at this early rather than later, and it's predominantly around visceral fat loss and improving muscle insulin sensitivity. And this is really regardless of your body mass index. And you have to use both strategies of caloric restriction, this is your nutrition tool, and also exercise, a combination of aerobic and resistance training to do this. So what have you learned here? Number one, insulin resistance is an important contributor of risk, and reducing insulin resistance is an important de-risking strategy. Exercise is an important tool here, and we'll go into a lot more detail specifically about kind of using exercise as a risk reduction tool, and nutrition, why using both of them together is a crucial application for reversing insulin resistance. Okay, let's move on to our next lesson, and this is all about lowering cholesterol values using lifestyle strategies alone. Okay, on to our next lesson, lowering cholesterol using predominantly lifestyle This is when we're trying to lower cholesterol specifically, and often really triglycerides as well, and non-HDL cholesterol for reducing cardiovascular risk using interventions that are not using our traditional lipid-lowering therapies. So what we're going to cover here in terms of what is possible when we're using this as our approach, and the different approaches that you can actually use, what are the likelihood responses that you can get, and understanding the variance here, and also really the limitations in terms of when we're using nutrition predominantly as a tool for reducing LDL cholesterol. And this is, I think, really one of the most common questions that I get, and what my general response to this is that you need to use, say, nutrition and these different interventions to solve the appropriate tool, and often nutrition is not the best tool for solving this problem. I think using nutrition is an amazing tool at decreasing cardiovascular risk, but we have to put everything in context, but I want to give you the framework of information here. What we know is that if you look at, say, LDL cholesterol, for example, genetics determine about 50% of the variance. So for a huge amount of people who are in midlife, their LDL cholesterol will have a huge contribution of its level by genetic factors, which means that for most people, they will have somewhat a genetic floor. So if they pull the levers of lifestyle factors, their LDL cholesterol may reduce, but typically it hits a ceiling and basically is unlikely to go down any further. But that is variable for a lot of different people. And this is one of the big takeaways here, is that the inputs that you use often get very, very variable responses. So some people, and you'll read about this online, will do an intervention from a lifestyle perspective and get a huge response. But again, you have to see on an N-of-1 basis if that response is going to be similar with you and what the intervention actually is and whether it's an acceptable thing and has any other side effects or kind of off-target effects. One of the most common questions here is going to be around saturated fats. And what I will say is that the evidence can be quite mixed here, or can be collated in such a way that actually points a very kind of damning case against saturated fats. And I would agree, most of the evidence actually points towards significant adverse outcomes and harm here, but there's mixture in the evidence base. What I would say is that most of the evidence for nutritional epidemiology studies is quite poor. So a reliance on that, I don't think, is very useful. So yes, really, if you're trying to paint a picture either side here, you can find a case series of studies that will actually support your argument, but I think we have to recognize the limitations of both sides of that argument in terms of the quality of the evidence that is used. I'm going to cover a couple of them here. If you look at a systematic review that was done of 37 guidelines, 108 systematic reviews, including 20 randomized clinical trials, there was a very high amount of evidence that foods high in unsaturated fat or low in saturated and trans fat, high in soluble fiber, reduce LDL cholesterol. So I think you could take away from that listen, if our objective here is to keep particle concentration as low as possible for long as possible, that seems like a good strategy. But you have to ask how much that intervention actually reduced LDL cholesterol, and you can see here that it reduced it by very modest amounts. Now again, this could make a big difference in terms of if you're doing this over your lifetime or certainly at a population level, and additionally the response that people get can be very, very variable. So some people can have no response, some people can have a huge response. You have to see how you personally respond to this. In terms of cardiovascular outcomes, this is an 8.5-year follow-up of UK Biobank data, and they looked at individuals who had higher saturated fat intake and looked at cardiovascular outcomes. And there was no relationship in terms of this particular study. But again, what I would say is that you're using nutritional epidemiology, and these studies can often, I believe, be very poor in quality. If you look at people who had higher saturated fat from meat intake, their cardiovascular outcomes actually went up by approximately 19%. And if you looked at higher dairy saturated fat intake, their cardiovascular outcomes actually went down by 11%. But when you adjusted both of these for BMI, so you counted for people's weight in this and ostensibly their visceral fat amount, the effect went away. So this is again, a super confusing area for people because they're seeing people using studies to heavily support their argument on one side and then heavily support it on the other, and people are left in the middle rather confused. What I would say is that you can find whatever evidence you want here, but the evidence on both sides is pretty poor. If you look at a Cochrane review, 15 RCTs over 50,000 people, really variable evidence. So this is a very, very busy slide. And typically when someone says that, they've included a slide that's actually too hard to interpret and probably shouldn't use, but I use it just to kind of to try and be as transparent as possible. If you look at the combined cardiovascular endpoints here, you can see that there was a reduction in cardiovascular endpoints supporting the reduction of saturated fat. But if you look at all the other endpoints in terms of all-cause mortality, cardiovascular mortality, myocardial infarctions, fatal and non-fatal stroke, coronary disease, coronary heart disease mortality, and cardiovascular events, there was no statistical differences. So again, lots of noise in here. And again, I think this noise is coming from really the way these trials are conducted. Now, we have to be mindful that this was only a 5-year follow-up. So when we try and put all the evidence together, we can see that the totality of evidence likely suggests that higher saturated fats are unlikely healthy in terms of using cardiovascular risk. But the issue here is that if you look at the observational data, the people who historically have been eating higher amounts of saturated fat have a significant unhealthy user bias. They're more likely to have other factors that increase their cardiovascular risk as well. And also people's ability to recall specifically how much saturated fat they have been ingesting is just incredibly hard to do. So most of the evidence, I believe, is not that robust. So you're dealing with very shaky grounds here. I think it's a reasonable thing to say that we should get our saturated fats from real foods, so that's avoiding processed foods. And for most people, it's a reasonable thing to keep it at less than 10% of energy intake. However, people's response to this is incredibly variable. Some people will be eating higher amounts of saturated fat, and it will, within their caloric guidelines, will make no difference to their LDL cholesterol, which is where I believe most of actually the risk comes from. If you look at lowering cholesterol, so what is it then that specifically works from kind of a lifestyle perspective? So if you look at reducing fat, for example, so you take reducing fat content in the diet and you reduce it from say 30 to 40% of energy down to 15 to 20% of energy, it does reduce total and LDL cholesterol by levels of 10 to 20%. So that's an LDL of 3.4 going to 2.7 or 131 going to 104. So again, not insignificant differences, but again, the variance of response is huge on an individual basis, and we have to see how it applies to each individual rather than just looking at population data. If you look at soluble fiber, there's been long-standing data to suggest that higher levels of soluble fiber decrease LDL cholesterol. So this is foods like oats and oatmeal, legumes, apple, various different things, sweet potatoes, Brussels sprouts, carrots, flax seeds, etc. And if you look at psyllium husk as a supplement, you can see that the higher dose of the supplement on a daily basis, the higher here is the greater in LDL-C cholesterol reduction. So there's a very clear linear relationship here, but again, more modest reductions. Reggie Spice, a very common over-the-counter supplement for LDL cholesterol lowering. You can see here you get in various different studies about a 15 to 25% study, which is 15 to 25% LDL reduction, which isn't insignificant. But the issue here is that the active ingredient is the same as some statin therapy. So you have a lot of people who will be very, very reluctant to go on statin therapy, but will very quickly go on Reggie Spice. And I think rather than using an untested, unapproved therapy that's bought over the counter without the same manufacturing standards and the same trial data behind it, you might as well, if you're going to use Reggie Spice, you might as well use one of the traditional therapies. Berberine, another therapy used frequently for LDL lowering. Very variable response, I suspect, based on certain kind of genetic phenotypes. Will often get an LDL-C reduction of about 25%, and as I said, often acts via the same pathways for PCSK9 inhibition. There are a variety of different supplements that have been shown to have variable effects on LDL-C lowering, and so this is an interested blinded randomized control trial versus placebo looking at LDL cholesterol lowering on a variety of different supplements that you can see that are listed here. Some of them had increased LDL-C modestly, and some of them decreased LDL-C modestly. But on average, when you put them all together, compared to a placebo, there was no real difference. So I think this says two things. One is the differences that they make are very modest and sometimes can be the wrong way. And thirdly, when you aggregate it out together, there's no real difference. But at an individual level, it's even going to be modest at an individual level. Again, going back to this variable response on an individual level. One of the questions that comes up quite frequently and is currently in the media is really about what is the impact of a ketogenic diet. So a ketogenic diet is obviously very high in fat, often saturated fat, and low in carbohydrates. So a ketogenic diet, we know this from the Virta Health data followed by about kind of 2 years, is very variable LDL-C cholesterol. So again, always going back to this variable response. If you look at their feeding studies, generally LDL-C will increase by about 1.8 millimoles or 70 milligrams per deciliter, but again, very substantial variability of response. We know that the ketogenic diet is often associated with this group called the lean mass hyperresponders, where some people get a very, very dramatic increase in LDL cholesterol with sometimes an average LDL of 8.1 or 316, and this comes down very, very quickly when the dietary strategy is stopped. And we don't fully understand this process, but we know that for some people they get a huge increase in their LDL-C or ApoB, circulating ApoB. So again, very variable response. So I think nutrition and supplements, they absolutely have their utility, but often the intervention, with the exception of the ketogenic diet, the response is usually modest, but often dramatic in both reducing and decreasing risk. When you're aiming for very low levels of LDL-C or ApoB concentrations, these interventions will rarely get you to target, and they may not be adequate in isolation. So when we're thinking about our overall strategy for reducing risk, we have to understand the limitations and the potential of the tools that we're using, and also when we're thinking about the literature in terms of where the data we're making our decisions from has come, we have to recognize the instability of that in terms of particularly nutritional epidemiology, where we cannot do very controlled studies over longer periods of time. So what have we learned here? Number one, what's possible in terms of using nutrition and other strategies from a lifestyle perspective, the different approaches that can be used to modify LDL cholesterol, but also the limitations in terms of our variability of response. Even when most people do get a response from a therapy, the response is modest, but if only a modest response is required, maybe only the lifestyle factors that are needed will be used. But for aiming for the very, very low levels to maximally reduce risk, and we want to pull that lever the hardest as possible, maybe we have to consider the introduction of medical therapies, which is what our next lecture is on, and that's all about lowering cholesterol, specifically LDL cholesterol, ApoB concentrations using medications. Okay, on to our next lesson, all about lowering cholesterol, specifically lowering ApoB concentrations using medications, what's possible and what are the risks and benefits. So what we're going to cover here is really, again, just a coverage of lifetime cardiovascular risk and how lowering lipoprotein levels, specifically ApoB or LDL cholesterol, actually impacts on that. What are the benefits that we can expect to see with LDL-C lowering, and specifically over what time frame? And then what are some of the options that we have available to us as therapeutic options? Now, again, it is always important to highlight that when we're talking about medications and drug therapy options, this is a conversation to have with your own doctor, because the individual components that will make up a decision to decide on a medication are always made in consultation with your doctor. So this is just a primer on some of the high-level topics, but all decisions here around medications need to be individualized and tailored to you and your conversation with your doctor. Fundamentally, getting back to our first module here, the understanding of atherosclerosis, and this is why it's so important to have an understanding of the condition. It is all about the abnormal retention of an ApoB particle in the artery wall and how that sets off an inflammatory cascade leading to the development of atherosclerosis. Now, we know, and I would hope that you have understood this by explaining all the risk factors, that ApoB and LDL cholesterol is not the only risk factor for cardiovascular disease, but it's an essential risk factor. You have to have the retention of that ApoB particle in the artery wall to set off that inflammatory cascade. When we're thinking about lifetime risk, the time horizons are crucial here, and this is why we always use lifetime risk rather than 10-year time horizons. If you look on the bottom axis here, you can see LDL lowering up to a magnitude of about 2 millimole. So when we actually look at the magnitude of risk reduction, so higher on the vertical axis here is better, you can see that with a 2 millimole reduction, you get a 20 to 30% reduction in risk, which is what we would expect. And that is what we've seen from most of the randomized controlled trials with average follow-ups around 5 years. When we start to look at prospective cohort studies, which again is more in the observational data side of things, with follow-ups of much longer periods, the risk reductions that you're seeing are in the order of closer to 50%. So again, the time horizon is the thing that is changing here rather than the reduction in LDL cholesterol. When you look at Mendelian randomization studies, so these are basically Nature's randomized controlled trials, basically have much longer follow-ups up to about 50 years. Now you're getting to 70 to 80% relative risk reduction. And so the key here is the magnitude of reduction in ApoB concentration as reflected here by LDL cholesterol. And you can see here a 2 millimole reduction is about 77 milligrams per deciliter. We're changing into different units for our US viewers. You can see here that the big difference here is not the LDL cholesterol, it's time. So when you start to lower LDL cholesterol is one of the most crucial and important components. And this is why waiting much later in life to initiate any therapies is arguably not the best strategy, because it is always about lifetime exposure to the particle concentration in addition to the other multipliers of risk. And going back again to our idea of cumulative exposure, and similar to pack years or cholesterol years, we know that 4,000 milligrams per deciliter or 103 millimole per liter years is where you don't really start to see any significant incremental risk in terms of cumulative exposure. And what that looks like in terms of LDL-C cholesterol is an LDL of 3.4 for about 30 years, 2.3 for 45, or 1.7 for 60 years, and here in milligrams per deciliter. So you have to ask, what is your expected lifespan, and over what time horizon will you accumulate that 4,000 milligrams per deciliter or 103 millimole per liter years? So the key difference here is that small changes in absolute risk result in big changes in absolute risk later in life. And this is where you start to see someone will say, well, there's a 1% reduction in risk. That is minuscule. We don't need to worry about that. And it is true over short time horizons, but over long time horizons, those big changes in absolute risk make a difference, which we have highlighted here in terms of our differentials of risk reduction over a lifetime period. So major lifetime risk reductions really are what we're aiming for. Yes, 5 to 10 year periods result in minimal reductions in risk, but this is where most of our trial data is always going to be actually derived from, because most interventional drug trials will not be able to be funded for 10, 20, 30 years. It's just not going to be possible. When you look at the statin treated group, so this is the primary therapy that is used for reducing lipids. There are a variety of other options which we're going to talk about, but this is kind of the base that has formed the therapy group for many, many years. If you look at the meta-analysis of these trials, I've purposely chosen this particular meta-analysis because it's often the one that's referred to by individuals who will point to the absolute, what they believe is that the failure of statin therapy for reducing risk. And so this is often used as their hallmark that they will hold up and say, listen, clearly the evidence is just not there. If you look at reduction in events in terms of all-cause mortality, heart attacks, and stroke, and you're looking at absolute risk reduction, so 0.8%, 1.3% for heart attacks, 0.4% for stroke. So when you look at this data, it really does not seem appealing that you would use any form of lipid-lowering therapy, specifically statin therapy. In this instance, putting all the trials together. And I agree, when you put that information together, it really doesn't seem that appealing. When you look at relative risk reduction, obviously the reductions are much bigger, but of course anyone who understands the difference between relative and absolute risk reductions will be able to tease this apart. The key part that is never pointed out for these studies is really that this was on a mean follow-up of 4 years. And really, again, we're talking about lifetime cardiovascular risk reduction rather than 4-year time horizons. So again, the absolute risk reductions over small time horizons will be small, whereas over long time horizons, they are always much bigger. And so what I would say to the individuals who use this as a significant criticism of statin trials is not that it actually criticizes or actually eliminates the argument for statin therapy. I would say that it significantly bolsters it and really just highlights that most of the people who are using this as a criticism don't understand how to interpret clinical trials. And if they do understand clinical trials, they're being deceptive because they're not giving you the figure of 4 years in terms of mean follow-ups. Because again, this is always about lifetime risk. The drug trials that we talk about in terms of randomized trials have shorter time horizons, whereas when you have longer exposure times, you get significantly more magnitude of risk reduction, whereas the absolute risk reduction actually grows substantially over time. So when we're thinking about therapies, it all depends on baseline risk and the time horizon over which we are managing that risk. Now you can say, how do we define baseline risk? One of the best ways of defining whether you have high near-term baseline risk is, do you have the disease or not? And this is where we go back to the idea of cardiac CT and the calcification score. Now, if you look at someone with a calcium score of 0 and you look at the groups who were on statin therapy or not on statin therapy, and this is not randomized data, if you look at the two groups here, and this is for calcium scores of 0 with a follow-up of about 10 years, you can see that there is no difference between the groups. So therefore, most people will say, if you have a calcium score of 0, yes, you have a very low near-term risk in the order of 10 years, and you are unlikely to benefit from statin therapy. Now, what I will say is you're very unlikely to benefit from statin therapy over a 10-year time horizon if you have a calcium score of 0. I entirely agree with that. And specifically, if you look at people who have a calcium score above 100 and below 400, you can see the differential between these two groups is quite substantial, with about a 60 to 70% relative risk reduction and about 8.5% absolute risk reduction. But again, it is about time horizons. We're not interested in 5 to 10 years, we're more interested in 50 years. So yes, if you're 80 years of age and you have a calcium score of 0, the probability of you benefiting from statin therapy is probably quite low. But if you're 40 years of age, the expected outcome here is that you will have a calcium score of 0, and the time horizon of interest is actually far longer than 10 years. So in terms of the therapies or options that are available to us, historically it was quite limited. Now we have a huge range of therapies beyond statin therapy. So statin therapy is our cornerstone here, but we have many more options that we can choose either in addition or as an alternative to this. And there seems to be an awful lot of resistance to statin therapy. I fully don't understand why. They're a great therapy if tolerated well, but we have other options if someone doesn't tolerate them. And we'll talk specifically about statin side effects in our next lecture. The statin options that are available are many and varied, but the two that are probably used most commonly are rosuvastatin and atorvastatin. Both of these are generic therapies, are incredibly cheap, easy to access, and in some countries can be bought over the counter. The second is ezetimibe, which acts through different pathways than statin therapies. And thirdly, we have bempedoic acid and PCSK9 inhibitors, and the newest being inclisiran, all acting through different pathways. The latter two in the area of small interfering RNAs or PCSK9 inhibitors, and the first three here being oral therapies, the second being injectable therapies. So all of them have shown to consistently and considerably reduce LDL cholesterol and ApoB concentrations, and all of them have hard outcome data in terms of reduction of major adverse cardiovascular events, with the exception of inclisiran, and that is an ongoing trial. So what is possible in terms of LDL cholesterol lowering when we use these different therapies, either in isolation or in combination? Again, a slightly convoluted graph here. I do apologize for that, but there's a lot to actually include here. When you're actually using bempedoic acid, you get about an 18% reduction. If you add ezetimibe in isolation, you have about a 20% reduction. Statin therapies, on average, at kind of moderate to high dose, you get a 50% reduction. If you're using a PCSK9 inhibitor in isolation, about a 55% reduction. In inclisiran, about a 58% reduction. As you begin to stack these therapies together in terms of either statins and ezetimibe, etc., or using ezetimibe and a PCSK9 inhibitor, you can see that you're getting down to levels of LDL cholesterol lowering of approximately 85%. So really, in terms of taking LDL cholesterol down from even extremely high levels down to the low levels that we're really aiming for reducing lifetime cardiovascular risk, is possible with the therapies that we have available to us. So it is all about targets, all about what are we aiming for over lifetime cumulative risk exposure. And we know that ApoB increases this, and we know we have an opportunity to lower it with the therapies we have available to us, which reduces cardiovascular risk. And we have the tools to lower it by about 85%. So the question really becomes, what is our lower bound target? And that is again about cumulative exposure over time, but also whether we're aiming to reverse coronary artery disease. And that is something we will talk about in a subsequent lecture. So what have we learned here? Number one, lifetime risk and how therapies impact on this are really, really important principles to understand. The benefits of drug therapy interventions and the time horizons, again, of interest. And thirdly, some of the options that are available. Historically, this was solely whether someone would go on statin therapy or not. Now we have a whole suite of different therapies that are available to us. And these are starting points for discussions with your own doctor. Again, any specific medical therapy, anything that is a prescribed therapy should be discussed with your doctor in terms of whether they're suitable for you. So in our next lesson, we're going to talk about specifically statin side effects, because this is a very frequently discussed topic, and we're going to dive quite deep into this. Okay, welcome to our next lesson, statin side effects. And this is a super interesting topic because there's a lot of myths out there that really need to be put in context. So what are we going to cover? We're going to cover three things primarily. Symptoms, what are the symptoms or side effects that can occur on statin therapy? Which of these are real and what happens when you substitute in a placebo? And what are our options when someone actually does have some of these side effects in terms of how we manage their cardiovascular risk going forward? Many of you will be aware that statin therapy, as our cornerstone of therapy for reducing cardiovascular risk, primarily by lowering ApoB or LDL concentration, is often seen as a very powerful tool or almost like the devil in terms of some therapy that we would use. So let's add some precision here around the literature in terms of side effects. The first thing to realize is that any medication can cause any side effect. Clearly, some medications cause specific side effects with a higher degree of frequency and some far less. But in general, we have to realize that any medication, in theory, can cause any side effects. The reality is the majority of patients who go on specifically statin therapies have no issues whatsoever. Secondly, people will often say when they're going on statin therapy, well, what about the side effects? And this is the expectation that they will have to endure a life of side effects. And no one has to endure a life of side effects. If someone has a real side effect and they are experiencing significant distress from it, we stop the medication. So this is one of those issues, is no one will have to experience a lifelong side effect on specifically statin therapy. The three main categories of side effects that we're going to discuss here are number one, the question around dementia, number two, the question around diabetes, and thirdly, the issue of muscle aches and pains. So firstly, the dementia question. This all stems from a 2012 FDA warning, which specifically said that rare post-marketing reports of cognitive impairments, as you can see listed here, are associated with statin use, and these reported symptoms are generally not serious. That was the specific black box warning that was produced by the FDA in 2012, so now many, many years ago, over a decade. The general public translation of this statement was that statins cause dementia. But let's look at the data. If you look at the follow-up data on this, so this is a study from 2021 with more than 20,000 people at more than 65 years of age on statin therapy. There was no increased risk of dementia, mild cognitive impairment, global cognition, or executive function, no changes in memory or language function. If you look at a 2022 meta-analysis of multiple different trials, including 5 million plus patients, there was no dementia risk identified, and actually there was potential benefit in terms of a possible reduction of dementia. So in terms of dementia, any medication could cause any side effect, but there is no convincing evidence that statin therapy in particular increases dementia risk. When someone says that there is a warning, they're referring back to the 2012 black box warning that was put on therapies, including statins. And as you can see from the follow-up data, including multiple millions of patients, we really do not have any convincing evidence that lowering LDL cholesterol using statin therapy produces any evidence of dementia, even at very, very, very low levels. So next, look at diabetes. So the general translation here is that statins cause diabetes, but let's look at the data. If you look at a meta-analysis of statin trials, you can see that there is a signal of increased risk of diabetes, and you can see an 11% increased risk in the Jupiter trial, which tested rosuvastatin. There was a 25% risk of increased risk of diabetes. However, let's look at the individual components of this. So 80% of those who did go on to develop diabetes on the therapy already had evidence of impaired glycemic control and were generally in the pre-diabetic category. So what we found is that the therapy, when those individuals were put on this therapy, it pulled forward their diagnosis of diabetes by about 5 weeks. The risk was small overall, and however, the individuals who actually did go on to develop diabetes, when actually stratified and looking at their benefit, they were likely to have a tenfold greater benefit in those who went on to develop diabetes. So there's still substantial risk reduction here. Now, that is not to say that we just allow patients to actually have worse glycemic control if we feel that the therapy that is being used is causing it. We have different options, what we talked about before, but we have to put all of this in context. The last area is probably the one that comes up the most frequently, and this is the idea of SAMs, or statin-associated muscle symptoms. Now, very serious muscle damage is actually very, very rare. So when you see this, it's very, very obvious, but it is very, very rare. What most people are talking about when they talk about muscle pain is this idea of this statin-associated muscle symptom or a muscle ache. And depending on the study that you look at, it ranges from about 7 to 29% of patients. And when you have a variability that wide, that tells you that there's something going on. We need to be careful about our interpretation of the data. Now, encouragingly, for patients who have these symptoms, the symptoms usually resolve very quickly on stopping the medication. So if you are put on therapy and you do develop those symptoms, we can just quickly stop the medication or come up with a different strategy and the symptoms just go away. So it's not, again, a lifelong set of symptoms that you would have to endure over periods of time. When you look at the blinded placebo-controlled studies, and you take people who are identified as statin intolerant, so this is someone who's gone through various different iterations of therapy, and they're being labeled as statin intolerant, and then you rotate them on a series of therapies over a year, on a statin, on placebo, and then on no treatment whatsoever, and you ask them to score their symptoms during these particular periods of time, and they don't know which they're on in terms of the statin or the placebo. Clearly they know when they're not on a treatment at all. And so this was a really, I think, groundbreaking study that really didn't take a huge amount to do, but has only been introduced to the literature in the last few years, and it's called the SAMSON trial. So if you look at the vertical axis here, you can see the symptom scores. This is not percentage of patients with an adverse event. This is a symptom score based on what they actually inputted at the time. If you look at people on no treatment whatsoever, so they're not taking any pill or tablet, they had a score of 8. If you look at people on placebo, they had a score of 15. And if you look at the people on statin therapy at the time when they were on the statin therapy, their score on average was about 16. So what you can see here is that between the placebo and statin therapy group, there is no difference in the symptom scores. And ultimately, this breaks down into people didn't have symptoms when they were on no pill, and they did have symptoms when they were on a pill. So the side effect profile was largely been driven by the fact of taking a tablet rather than the active ingredient of the statin therapy. When you look at the meta-analysis of individual level data on patients who are in statin trials, and you look at those on statin therapy and on a placebo, statin in the white here, placebo in gold, you can see percentage of adverse events on statin therapy group 27%, placebo group 26.1%. And this is in 19 placebo control trials using about 94,000 patients. So yes, there's an increased risk. It is an absolute increased risk of about 0.5%. But in general, we can say that more than 90% of all reported muscle adverse symptoms effects are not due to statin therapy. It is due to a combination of factors, more likely the nocebo effect. The nocebo effect is the inverse of the placebo effect, where someone derives an adverse outcome rather than a benefit from an input that doesn't have an active ingredient. So the thing that people often feel when they are in this category is they're told that it's all in your head. Now, the reality is in my experience, every experience is in your head. This experience of listening to this lecture right now is in your head. Every memory, every dinner, every relationship has all been in your head. It's still real. That is the problem. That is the challenge that we face. Even if the side effects that people encounter are nocebo-based and they are not actually secondary to an active ingredient in the statin therapy, the reality is those symptoms are still real and still, for many people, cause significant distress, and we have to navigate around that. So again, this is not about saying that the symptoms that you have are nocebo effects, so just carry on. We have to be realistic about how we approach this. In terms of our options for what we can do here, often we can go with a lower dose, or we can switch to an alternative therapy. And sometimes it takes switching to 2 or 3 different therapies before you actually get one that you can tolerate and that you get your lipid parameters down to target. But again, remember, we have lots of different options here. Fortunately, we don't have a kind of placebo that we can prescribe. Telling patients to come off the therapy for 2 weeks and then go back on is a reasonable strategy to do to see if they actually have temporal resolution of side effects and then recurrence when they go back on. But the reality is the patient themselves, you know that you're going off the therapy and on the therapy. In terms of things that you can take alongside it, there really is limited evidence for CoQ10. This is often advised for people who are going on statin therapy or have SAMs or muscle aches, and really the evidence here is highly confounded. The reality is we have lots of other alternatives to statin therapy, and sometimes just a low dose is necessary in combination with other therapies. So what have you learned here? Number one, symptoms and adverse effects that are often ascribed to statin therapy in the 3 main categories. Which of those are real, and what happens when we substitute a placebo, and our options in terms of navigating this problem when you encounter it in clinical practice. Okay, so on to our next lesson, and this is all going to be about exercise strategies in terms of reducing cardiovascular risk. Okay, on to our next lesson here, exercise strategies part 1. So this is a 2-part series which we're going to break down with a primary emphasis here on aerobic training, which will in truth be the biggest lever that we can pull goal from an exercise perspective. So what we're going to cover here are, again, covering the benefits of exercise and reducing cardiovascular risk and all-cause mortality. We're going to talk about aerobic fitness, again, how we classify it, what targets we should be aiming for, and looking at them with specifically longevity in mind, and also our aerobic base, how assessing our zones and lactate clearance can really inform us about how we're going to deploy exercise as a strategy and how we're going to use it to decrease risk. So exercise as a strategy for reducing risk, as we've said many times already, is exercise is the single best thing you can do to extend lifespan if we were to extrapolate from the observational data that we have in terms of reduction of all-cause mortality. Now, what I would say is even if the observational data is significantly overestimating that benefit, and there is a significant contribution of reverse causality, we have to look at it insofar as the quality of life increases that can happen, even if there was no increase in lifespan. So that is how I always think about it in my mind. Even for the time that we have, we want to maintain our functional independence for as long as possible, and exercise is going to be a core component of how we do that. As we've gone over several times, the relationship between fitness and mortality, the chances of dying from any cause, is very clear and a linear relationship. The higher your aerobic fitness, as described by Metz here, the significant reduction that is achieved in terms of relative risk of all-cause mortality, and that has been replicated in multiple trials. Again, going back to our keystone trial here in terms of fitness and 10-year survival, looking at those in the top 2.5, 2.3% of VO2 max, you can see here that being at the very, very top levels, obviously a 5-fold difference in all-cause mortality over a 10-year period, but even going from low, which is below the 25th percentile, to above average, you can see a huge increase in benefit. So really the key here is not to be put off by the opportunity to get into the top 2.5%, but really is to be encouraged that it takes very little to actually get off zero and start accruing substantial benefit. So in terms of how we're going to prescribe exercise, in terms of how we will do this, we have to look at, again, our aerobic fitness target is increasing the size of the area of that triangle, which is formed by our metabolic flexibility and metabolic health, the lactate clearance at the bottom, and then that will determine the potential higher end of our pyramid in terms of VO2 max. So aerobic base training should form the basis to offer for most, if not all, of our exercise training. And we're going to talk about strength and resistance training in a separate lecture. So when we look at how we're going to do this, our goal, if you want to take it to the most kind of theoretical maximum, is to emphasize exercise at a level or intensity that is happening at less than 2 millimole. So as we look at here, as we had seen in previous lectures, the goal here is to keep, we're looking at speed in this instance, but we could look at watts or heart rate, we're keeping it at below 2 millimole. And that is our goal here for the majority of the time. If this is something that captures your attention and you're willing to do that, doing the lactate threshold testing series on a regular basis is, I think, really worthwhile. Some individuals will even buy a home lactate testing meter. I've done that and I found it really, really helpful for me. But there are other ways that we can do this, but really this is what we're aiming to do. The way that we actually then apply this in terms of the test is to define a series of zones. Now, in terms of defining exercise zones, there are multiple different ways that you can do it, and it can often be quite confusing when people start interchangeably using these zones. So I will use a 5-zone system. Sometimes people use 6 and on, but there are multiple different ways to do it. In this instance, we're going to use 5. I'm going to define those zones primarily by the fuel source that is used to power that zone. So in zone 1, it is predominantly fat. In zone 5, it is almost all carbohydrate. So it's really a balance between the two. In zone 2, you're using much more fat as fuel rather than carbohydrates, and then in zone 3 and above, you're switching much more into carbohydrates, and in zone 5, exclusively carbohydrates. So that's a good way to think about it. Our base building will happen primarily in zone 1 and zone 2. Now, in terms of VO2 max building, you will need to include zone 4 and 5, but a significant contribution over very long periods of time to your VO2 max will be as a function of your base. Remember, to build that big pyramid, you need a big base. So again, it's not just VO2 max being solely as a function of zone 4 or 5. That is required for sharpening and ultimately to take it up that little bit higher. But to really get there, you need that big base. So that is where 80 to 90% of our time should be focused, and maybe 10 to 20% of our time in terms of aerobic activity should be in zone 4 or zone 5. And that is really with the emphasis of keeping lactate at less than 2 millimole if you have a way to precisely define that. Okay, so when we are looking at our lactate threshold, we can see at the bottom here we've got speed. As I said, you can have it as watts or heart rate, and then you can apply that to your zones. If you do the test, the person will be able to give you a prescription, and that as you change your fitness, that prescription will change. As we spoke about before, our objective here is to have the maximum amount of power. We're describing watts here, and this is a metabolic syndrome patient before our lactate starts to climb. So this is the metabolic syndrome patient or recreational athlete, and then the performance athlete can achieve a huge power output in terms of to do that. And that is really an illustration of incredibly healthy mitochondria. That is an illustration of exquisite insulin sensitivity. So as we approach this problem, some people will find it somewhat of an obstacle to do lactate threshold testing. They will see it as too complex, and they want to have a much more kind of simple and approachable way to define zones. What I would say is just like how we define insulin sensitivity and resistance, we have to trade off accuracy for simplicity. So as you use more simplistic methods to define this, we have to be honest that our degree of precision here is going to fall away a lot. And this is particularly the case when you're dealing with very, very trained athletes or very, very untrained individuals. So for most people, even a simple walk will push them right up the degree of zones quite quickly. So a way to easily approximate this, but again, we will lose some of the precision, is zone 1 is a very, very easy pace. It's very comfortable to talk, and often this is walking a very, very easy bike. And I've included a very easy run here, but that would be for an exquisitely fit individual. Zone 2, again, an easy pace, can comfortably talk, but you're aware of breathing faster, and this is kind of an easy run or easy bike. When we get into zone 4, it's quite a fast pace, difficult to talk, and you're talking about kind of fast run or bike. And zone 5 is all out. You really can only get out short phrases, and it's a maximal all out effort. One of the ways that people will define their zones is that there are automatic calculations on your watch. So most smartwatches will be able to dial in what they feel are zones based on your previous activity, your age, etc., and will give you specific zones. Historically, these have been pretty unreliable, and the one that I definitely wouldn't use is 220 minus your age. One way to give a rough approximation, and is an easy way to do it, is using what's called the Maffetone method. So this is from the work of a guy called Phil Maffetone, and basically it is taking subtracting your age from 180. Now, when people do this, they will find that this is to set your aerobic zone. They will find that it's a heart rate that's very low, and often they will get there very quickly with a very minimal amount of exercise, and they'll be quite frustrated. But this is just the truth in terms of most people's physiology. So if you're going to use a heart rate monitor exclusively and you're using an age as a reference for this, be very conservative, use the Phil Maffetone method. There are other ways that you can do performance run tests over 20 minutes to dial in your figures, and I would argue you probably use these performance tests. If you simply put them into YouTube, you'll be able to find that, or use the Phil Maffetone method. Another way is what's called the talk test. So you're doing an activity whereby you can continue to talk, say on a conference call, but other people on the conference call would know that you're talking. I think this is a reasonable way to do it, and it's a reasonable way just to, I think, keep a cap on your degree of activity to hold you back generally. But often you'll find, and this is particularly the case for very untrained individuals, that even using that, they're way above a lactate of 2. Another way to do it is what the nose breathing test. So you continue to increase your speed, your watts, for example, and you're breathing only through your nose and not through your mouth. And then the point at which you have to switch to nose and mouth breathing is really when you've moved out of aerobic into an anaerobic zone. It's a rough estimation, and I think as an approximation, if you're doing that activity most of the time in a nose breathing heart rate zone or speed, for example, I think it's a reasonably good approximation. In general, walking is an excellent way for zone 1 and for a lot of people, zone 2 activity. And I think it's underappreciated. We talk about steps, and I think steps and activity are great, but long walks are absolutely phenomenal in terms of optimizing your metabolic health and increasing that metabolic base. In terms of how much should people be doing, the general recommendation is 150 to 300 minutes of activity. So that's not necessarily even dedicated exercise, but I would argue that people really need to be getting as much as they possibly can, and aiming for 30 to 40 minutes of zone 1, zone 2, 5 days per week is a reasonable target to actually aim for. Have that as 80 to 90% of your activity. And VO2 max training will typically be broken down into sets of intervals. There's multiple different interval protocols and structures that you can use. A very common one is a 4x4 interval, so it's a 5 to 10 minute warm up either side of this, and you're doing 4 minutes continuous hard activity. Now you need to pace yourself because you want to try and have that second 2 minutes as being very hard, but you want to have enough in the tank to do it. And then you're doing 3 to 4 minutes of active recovery between these, and then 4 again. People do these often as skill repeats, for example. Usually you only need to do it about once a week as part of optimizing your VO2 max training. And when you put a protocol like that together from an aerobic fitness perspective, the area of your triangle here will improve substantially, particularly if you haven't trained before. So the speed of change will change significantly. Your lactate clearance will improve quickly. Your aerobic base will improve quickly. Your VO2 max will probably increase, but it takes a lifetime of activity to really build up that aerobic performance. And if you look at people aiming for very high VO2 maxes and aerobic capacities, it takes 10 years to really build out that engine to do that. In terms of the breakdown of activity, really zone 1, zone 2 training is 80 to 90% of your aerobic training. Zone 5, in terms of very high interval sprints, only 10 to 20%. So really the bulk of this here is zone 1, zone 2. The rest of it is going to be made up with resistance training and focus on balance and flexibility. So you need to have that balance and flexibility to be able to do the other activities, aerobic and resistance training. And even when you look at elite athletes, people who are world class in what they do, the majority of the time they're spending in a lower intensity. Now, you remember from our graphs, their low intensity is likely a very fast pace for you. So you probably may not even be able to keep up with them at a low intensity. And that is because of their efficiency of generating power at low lactate levels. And that is something you can build up to over time. And in general, I would repeat, for many people, zone 1, zone 2 can be achieved even with walking. And mostly, if you're looking at this and you're saying this is way too complicated, I don't want to get into this degree of detail and tracking heart rates and all this kind of stuff, just move, and lots and lots and lots and lots of movement. If you do that, you won't go wrong. So what have we learned here? Number 1, the benefits of exercise in reducing cardiovascular risk and all-cause mortality. Aerobic fitness, how we classify aerobic fitness and what targets we should be aiming for across the specific domains. And aerobic base in terms of how we can assess zones and lactate clearance and how we use that information to inform our training going forward. So to our next lecture, exercise strategies, part 2. Welcome to part 2 of our exercise strategies for reducing cardiovascular risk. And what we're going to cover here is around resistance training, particularly just looking at the importance of muscle mass and muscle strength, how we test that so you can inform your training going forward, and then go how we think about resistance training programs in general. And there are some specific differences here in terms of aerobic training that we really need to include. So when we talk about fitness in general and aerobic fitness, we talk about VO2 max and lactate clearance, and basically these being the 2 parameters of that triangle. When we include the pyramid in terms of including the base of muscle metrics in terms of mass, muscle strength, and muscle power, they're the things that also hold up all of this. So what I would say is in terms of picking these as strategies, the emphasis in my view needs to be on aerobic training as the key component here and taking up the bulk of your time, but there has to be significant contribution to muscle mass and muscle strength development to maintain your functional independence over time. But what we found is that the investment of time that you need to put into this particular type of training is generally often less than the aerobic training. So the reason we do this is for functional independence, and in terms of looking at our muscle mass declines between the ages of 20 to 40, most people will lose a significant amount of their muscle mass, and after age 40 we lose a substantial amount more. We know that when someone is admitted to the intensive care unit, they're losing 2% of muscle mass a day. So in generally later years, people are admitted to hospital for a variety of different conditions, and the rate of muscle mass during these periods of time can be quite substantial and often is rarely recovered back to their functional baseline. We know that low muscle mass is associated with significantly higher likelihoods of early death, and low muscle strength, that risk is twofold higher. And as we spoke about previously, if we were to choose a performance metric in terms of mass or strength probably outperforms in terms of its predictive capacity, but it's very hard to have high muscle strength without increasing muscle mass. So really the key here is preserving both muscle mass and strength over time. We know there's very clear data, as we've gone over previously, in terms of the higher quartiles of muscle mass lead to low overall mortality risk, and low muscle mass, there's a 50% increased risk of premature mortality. So that really sets the stage for kind of why resistance training in addition to aerobic training is so important. Because if you look at the literature, much more people do aerobic training rather than resistance training, and a lot of people who are particularly into aerobic training are often reluctant to engage in resistance training. So I think it's really, really important that this is included for people. And I personally was someone who neglected my resistance training for many years, and I know that when I've invested the time, effort, and energy, I really noticed the benefit even in my age category. So how do we go about assessing muscle mass and strength? As we talked about before, the gold standard really for muscle mass is the DEXA scan, looking at a factor like appendicular lean mass, which can be calculated off the figures in your DEXA scan. And this is really the sum of your upper and lower limb masses in kilograms divided by your height in meters squared. This is often not directly reported on your DEXA report, and sometimes you will have to ask someone to do this for you, or you can even do it yourself if you feel comfortable. But what I would advise is that if you've not done it before, you do it with somebody who has experience in doing it. You then look at the figure that is outputted as part of your appendicular lean mass, and what you're trying to do is map it onto where you would like to be in terms of an age match percentile. And at a minimum, you want to be above the 50th percentile for an age match peer. You ideally want to be above the 75th percentile, and you have to choose the target that is right for you, but you definitely want to be above average. A way to assess muscle strength, so not muscle mass but strength, grip strength is probably the most commonly used. It's not that grip strength in isolation, as we spoke about before, offers a significant advantage, but it is a very significant aggregator of strength. It's easy to do using a dynamometer. Basically, this is easy to purchase and use. You can buy them on Amazon, and it's usually measured in kilograms. And generally, hands down by your side, 3 attempts, and you take the best results and you compare to normative data. You can see here these are the average scores, and this will be available as a download for you as part of our worksheet. And you can see here these are the average scores for males and females in different age categories, and you can see where you fall with respect to these. And you can also also use this for a slightly more comprehensive breakdown in terms of quartiles and where people describe in terms of males and females in normal and weakness. You really don't want to be in the weakness category here for the quartiles of grip strength. Another way of doing this that's a really good integrator of strength is a home test you can do called the chair test. So a stable chair, often against a wall, with your arms across your chest, feet flat on the floor, and from the seated position you stand and sit, which is accounting for 1 rep, and you do that as many times in 30 seconds. You then count the reps, so that the rep, as I said here, is going from the standing to seated position, and you do that in 30 seconds, and you count the number of reps. You then map that onto a percentile score here in terms of below average, average, or above average, and looking at sex and age. And again, as always, we're aiming for above average in terms of what we're doing. You can see here, this is for males and this is for females. And ideally, you can use this to track performance over time. But when it comes to muscle strength, there's multiple ways of doing it. And it's not that strength in one particular muscle is more advantageous than others. You're aiming for whole body strength, but you're just testing one particular element of it. Now, in terms of resistance training, how much is the question that people often ask? If you look at the literature here, you typically 1 to 2 sessions a week, or kind of like you're talking about 40 or 2 40-minute sessions a week is typically adequate for most people. But you also have to look at what your goals are. If you're trying to hit bigger goals, you may need to put in more effort. There is some literature suggests that very high levels of resistance training are actually associated with worse outcomes across certain domains. I'm not entirely convinced of that data, and I suspect part of that is confounded by the fact that people are doing huge amounts of resistance training, and they're often compromising the amount of time that they're able to devote to their aerobic training. But generally, 2 sessions a week at a minimum are a reasonable target. The one thing I would say about resistance training as opposed to aerobic training is that it's easy to get into aerobic training and do so without much guidance. I would generally advise guidance if you can get it, but for resistance training, for anyone that is getting into it for the first time, and even if you're relatively experienced, I think coaching is absolutely essential. It doesn't mean that you have to have a personal trainer that you do every single session with. Getting guidance on specifically form and setting your program out for you and building that out over time is absolutely critical. The probability of injuring yourself here starts to increase as the weights increase, and also when you do potentially injure yourself, which is likely to happen, you need someone who's going to be able to understand why that injury happened, give you appropriate rehabilitation, and then also get you back on track and push you back up the ladder again here. But ultimately, this is down to what is your target? What are you trying to aim and hit at in terms of your muscle strength and muscle mass parameters? And ultimately, we can only decide what that is for ourselves. But ultimately, I believe that inclusion of resistance training for the development of muscle mass and muscle strength, based on the literature that we have in terms of longevity and also quality of life over time, is absolutely critical. So if this isn't something that you have considered, I really do hope that with proper guidance that you can build it into your training protocol and make this something that increases your quality of life. But again, as always, for these training approaches, particularly around resistance training, I believe that getting appropriate specialist expertise guidance is one of the most critical components, and it certainly was for me. So what have you learned here? Number 1, muscle, the importance of muscle mass and muscle strength in terms of how it impacts risk over time, how we test muscle mass and muscle strength, and then training, how to think about how to integrate resistance training into your programs overall and getting guidance in terms of how to do so. So onto our next lesson, lowering blood pressure using lifestyle measures.